welcome to the Deep Dive. Today, we're really getting into a critical health topic, diabetes.
That's right.
We're using a pretty detailed medical chapter as our guide here, and the goal is to pull out the really essential stuff for you. What is it? How common is it becoming globally and in the U.S.? And crucially, its huge impact on health, especially when it comes to vascular disease, our blood vessels.
Exactly. And we know you want to understand these complex health issues properly, but, without getting lost in all the jargon.
Right.
So this deep dive, it's really set up to give you the key facts, highlight maybe some surprising things, and connect the dots on why it all matters.
Okay, great. Let's start right at the beginning then. In simple terms, what actually is diabetes?
Okay, so at its core, diabetes is a chronic or long-term condition where your blood sugar levels are consistently too high.
Hyperglycemia.
Right, hyperglycemia. And it comes down to insulin. Either your body doesn't make enough of it, that's type 1 diabetes, or, much more commonly, your body's cells become resistant to the insulin you do make. So the insulin can't do its job properly. That's type 2.
So the insulin is there, but the cells aren't responding.
Pretty much. You can think of insulin as like a key that lets sugar into your cells for energy. In type 2, the locks on those cells get sticky, less responsive.
Got it. And you mentioned how common it is. It sounds like this isn't a small problem. How widespread are we talking globally?
Oh, it's huge. The numbers are really quite stark. Globally, the prevalence has nearly quadrupled in just the last few decades.
Quadrupled. Wow.
Yeah. Right now, estimates are around 425 million people diagnosed worldwide.
425 million.
And the projections. They suggest it could hit over 629 million by 2045.
That's unbelievable. What's driving that huge increase?
Well, part of it is demographic changes, population growth, aging. But a massive factor is modern life, really. Industrialization, economic development. It often brings an abundance of cheap, high-calorie food and, more sedentary lifestyles. People aren't moving as much.
Right. Less physical activity.
Exactly. And that combination, especially in countries seeing population growth, fuels obesity, which is a major driver for type 2 diabetes. It creates this environment where insulin resistance just thrives.
Okay, that makes sense. What about here in the U.S.? What do the numbers look like?
Here, the figures are also, they're very concerning. About 10.5% of the population has diabetes.
10.5%.
Yeah.
It's about 34 million people.
Roughly, yes. 34.2 million. But on top of that, there's another 88 million Americans who have prediabetes.
88 million. Wow. And prediabetes it's like the stage before?
Exactly. Blood sugar levels are higher than normal, but not quite high enough for a type 2 diagnosis. It's a major warning sign, though, a huge risk factor for developing full type 2 later on.
So adding those together, that's an enormous portion of the population affected or at high risk. Is it mainly older people we need to worry about?
Well, age is a big risk factor. The risk definitely goes up as you get older. About 27% of Americans over 65 have diabetes.
Over a quarter.
Yes. But, and this is important, we're seeing a definite shift. It's affecting younger people more and more.
And that's linked to the obesity rates you mentioned.
Largely, yes. The rise in overweight and obesity across all age groups is a major contributor to seeing type 2 diabetes in younger adults and even adolescents sometimes.
So it's really hitting across the board. Are there disparities? Do certain groups face higher rates in the U.S.?
Yes, unfortunately, there are significant differences. The prevalence rates vary quite a bit across racial and ethnic groups.
Who's most affected?
American Indians and Alaska Natives have the highest rates. Then Hispanics and non-Hispanic blacks also have higher rates compared to non-Hispanic Asians and non-Hispanic whites, who tend to have lower prevalence.
That really highlights how complex this is, with social factors clearly playing a role, too.
Absolutely. It's not just biology. It's intertwined with access to healthcare, healthy food, safe places for activity, many things.
Okay, so we have this widespread condition hitting some groups harder than others. What about the cost? What's the economic burden look like?
It's substantial, really substantial. People with diabetes, their medical costs are typically 2 to 3 times higher than people without it.
2 to 3 times.
Yeah. And the total cost in the U.S., back in 2017, the estimate was $327 billion.
$327 billion in 1 year.
Yep. And that breaks down into about $237 billion in direct medical costs, hospital stays, doctor visits, medications, supplies, that sort of thing.
Okay. And the rest?
The other $90 billion is indirect costs, things like disability, lost work productivity, people unable to work. and unfortunately premature death.
Premature deaths. How significant is that?
It's estimated there are around 270,000 deaths related to diabetes in the U.S. each year. So it's not just the financial strain, it's a tragic human cost too.
Absolutely. 270,000 deaths a year.
Okay.
Now, the chapter we're looking at really hammers home the health consequences, particularly vascular disease. Let's get into that. How does diabetes damage our blood vessels?
Right, this is key. The main long-term damage from diabetes really centers on the blood vessels. We usually divide it into two categories. Microvascular.
The small vessels.
Exactly. Affecting the tiny blood vessels.
Right.
And macrovascular, which impacts the larger arteries.
So it attacks blood vessels of all sizes.
Pretty much, yeah. The high blood sugar sets off this chain reaction of damage. It's not just about glucose numbers. It's about what that glucose does to the lining and function of your entire vascular system.
Let's start with the microvascular, the small vessel problems. What are the biggest worries there?
The two major ones are retinopathy and nephropathy.
Okay, what are those?
Retinopathy affects the tiny blood vessels in the retina at the back of your eye. Over time, this damage can lead to vision loss and even blindness.
Blindness. How much higher is the risk?
For people with diabetes, the relative risk of blindness is about 20 times higher compared to those without diabetes.
20 times.
Yeah. And then nephropathy, that's damage to the small filtering units in your kidneys.
The ones that clean your blood.
That's right. And if that progresses, it can lead to kidney failure, or what's called end-stage renal disease.
And the risk there?
It's about a 25-fold higher relative risk for people with diabetes.
Wow. Okay, so protecting your eyes and kidneys is a huge part of managing diabetes.
Absolutely critical.
Now, what about the macrovascular side, the larger blood vessels? What kind of problems arise there?
So with the larger vessels, the main issue is atherosclerosis.
That's the hardening of the arteries, right? Plaque buildup.
Exactly. Fatty deposits or plaques build up inside the arteries. This narrows them, makes them stiff, and restricts blood flow.
And where does this cause problems?
It significantly increases the risk and severity of several major conditions. There's peripheral artery disease, or PAD.
Affecting the limbs?
Yes, especially the legs and feet. Then there's coronary artery disease, CAD. That's the arteries supplying the heart muscle itself.
Leading to heart attacks.
Potentially, yes.
Yeah.
And finally, cerebrovascular disease, CVD, which affects the blood vessels going to the brain.
Which can cause strokes.
Correct. So diabetes basically accelerates and worsens this artery clogging process throughout the body.
And you mentioned heart disease. CAD is a particularly big issue.
It really is. CAD is actually the leading cause of those 270,000 diabetes-related deaths we talked about each year in the U.S.
The leading cause of death.
Mm-hmm. And people with both diabetes and CAD, they tend to have worse outcomes. They often develop CAD much earlier, sometimes up to 15 years earlier than someone without diabetes.
15 years earlier.
Yeah. And once they have CAD, they face higher risks of, well, cardiovascular death, repeat heart attacks, stroke, even clots forming and stents put into open arteries. They also tend to have tougher recoveries after a heart attack.
That really paints a stark picture for heart health. What about the brain? You mentioned stroke risk doubles.
At least doubles, yes. And like CAD, strokes often happen earlier, maybe about 2 years earlier on average in people with diabetes.
And the recovery is harder?
Often, yes. Functional outcomes, things like walking, speaking, daily activities, tend to be worse after a stroke if you have diabetes.
Is that just about blood sugar control at the time?
That plays a role, especially during the acute treatment phase. High blood sugar then is linked to poorer outcomes. But interestingly, just the duration of having diabetes, how many years you've had it, seems to be an independent risk factor for ischemic stroke, the blockage type.
So the longer you have diabetes, the higher the stroke risk, regardless of control.
It seems to contribute independently, yes. And after having one stroke, diabetes doubles the risk of having another one.
And long-term disability.
That's a major issue for diabetic stroke survivors. While the immediate death rate from the stroke itself isn't drastically different, a higher percentage face long-term disability and are less likely to regain independence compared to non-diabetic survivors.
Okay. Now let's turn to the limbs peripheral artery disease, PAD. You mentioned earlier it accounts for a huge percentage of amputations.
Yes, about 60% of non-traumatic lower limb amputations are related to diabetes. It's a massive problem.
And PAD itself is more common in diabetes.
Much more common. Prevalence can be as high as 40% in people with diabetes.
20%.
Yeah. And the risk goes up with age, smoking, how long you've had diabetes, how well it's controlled, and whether you have nerve damage, neuropathy.
Are there demographic factors too?
Yes, we see higher rates of PAD in African Americans and Hispanic Americans who also have diabetes.
And does diabetes make PAD worse or just more likely?
Both, really. It increases the likelihood, and it tends to make the disease more severe. Insulin resistance itself seems to be an independent risk factor for developing more severe limb ischemia, meaning really poor blood flow.
Does it affect the arteries differently?
Often, yes. In diabetes, PAD tends to affect the arteries further down the leg, more distal arteries below the knee. That can make treatments like bypass surgery or stenting more complicated.
And neuropathy plays a role here too.
A huge role. Nerve damage means people might not feel pain from sores or injuries on their feet, or even from the lack of blood flow itself.
So they don't realize there's a problem until it's serious.
Exactly. And neuropathy can also cause foot deformities, which create pressure points and increase the risk of ulcers forming. It's this terrible combination: lack of sensation, poor blood flow, and higher risk of infection if an ulcer develops. That's what leads to the high amputation rate.
And having both PAD and diabetes, that affects overall survival too.
Definitely. It significantly ramps up the risk of major cardiovascular events, heart attack, stroke, and overall mortality. It's a very high-risk combination.
It really sounds like diabetes just sets the stage for vascular problems everywhere. The chapter digs into the why, the pathophysiology. Can you break down the main biological things happening?
Sure. It's a mix of things. You've got metabolic problems like the high sugar and insulin resistance themselves. You've got issues with blood clotting. It becomes hypercoagulable, more likely to clot. There's chronic inflammation. There's dysfunction in the blood vessels themselves. And then there's the neuropathy we've discussed.
So it's like a multi-system attack.
You could say that. It shifts the whole environment within the blood vessels towards what we call an atherogenic phenotype, basically, a state that promotes atherosclerosis.
And what does that involve?
Things like damage to the endothelium, the inner lining of the blood vessels, increased oxidative stress, which is like cellular damage from unstable molecules, and platelets, the clotting cells, become hyperactive.
Okay, let's unpack those. You mentioned endothelial dysfunction. That lining is really important, right?
Absolutely crucial. The endothelium does so much: regulates blood vessel tone, prevents clots, controls inflammation. When it's not working right, that's endothelial dysfunction. And it's a really early and critical step in developing vascular problems and diabetes.
What causes the dysfunction?
The main culprits are the high blood sugar itself and the insulin resistance. Both are linked independently to atherosclerosis and cardiovascular risk.
How do they damage the endothelium?
Well, one key thing the endothelium makes is nitric oxide, or NO. It helps relax blood vessels, reduce inflammation, stop clots. But high blood sugar reduces NO availability, partly by increasing damaging molecules called reactive oxygen species, or ROS. These ROS directly damage the endothelium and chew up the nitric oxide. Impaired insulin signaling also reduces NO production.
So less relaxation, more inflammation.
Right. And high sugar also triggers pathways that cause inflammation directly and make immune cells, monocytes, stick to the vessel wall monocyte adhesion, which is an early step in plaque formation.
And insulin resistance adds to this.
Yes. Besides impairing NO production, it also increases production of endothelin-1, or ET1, which constricts blood vessels. Plus, in type 2 diabetes, especially with obesity, you often have high levels of free fatty acids, which also directly harm the endothelium.
And cholesterol.
Yes, the typical pattern in diabetes: high triglycerides, low HDL, or good cholesterol, sometimes altered LDL or bad cholesterol, what we call atherogenic dyslipidemia, adds significantly to the risk as well.
Okay, so the vessel lining is taking a beating. What about the platelets and clotting you mentioned, this procoagulant state?
Right. Platelets become dysfunctional too. Certain proteins on their surface get ramped up, making them stickier and more likely to clump together.
So they aggregate more easily?
Yes. And the high sugar messes with calcium levels inside the platelets, which also affects how easily they get activated. On top of that, in chronic high blood sugar, the balance shifts. You get more pro-clotting factors circulating in the blood and fewer natural anti-clotting factors. An overall procoagulant state. The blood is just generally more prone to clotting. So if an atherosclerotic plaque ruptures, you're much more likely to form a dangerous clot that blocks the vessel, causing a heart attack, stroke, or sudden worsening of P.
Okay, given all these risks, endothelial dysfunction, clotting, PA, CAD, stroke, how should doctors be checking on the vascular health of patients with diabetes? What does a good evaluation involve?
It needs to be comprehensive. Definitely includes checking for neuropathy, doing a careful foot exam, and using non-invasive tests to check blood flow.
What does the foot exam look for?
Things like changes in the skin. Is it thin, shiny, dry? Hair loss on the toes or feet? Any signs of ulcers, calluses, redness, warmth, suggesting infection, nail problems, deformities?
And the neuropathy check.
That involves testing sensation. A common tool is the Semmes-Weinstein monofilament test, basically testing sensitivity to light touch. Also checking vibration sense, maybe pinprick, and reflexes. We're looking for that typical glove and stocking pattern of sensory loss in the feet and hands.
And you said pain isn't always a reliable sign.
Not at all. Significant nerve damage can exist without much pain, which is why the objective testing is so important.
What about testing blood flow directly? You mentioned ABI earlier.
Yes, the ankle brachial index. Comparing blood pressure in the ankle to the arm. It's a standard screening test, recommended starting at age 50 for people with diabetes, or earlier if they have other risk factors, and then maybe annually for high-risk folks.
But you mentioned it can be misleading sometimes.
It can, yeah. In some people with diabetes, the arteries in the lower leg become calcified and stiff, so you can't compress them properly to get an accurate pressure reading. This gives a falsely normal or even high ABI.
So what do you do then?
In those cases, measuring the pressure in the toes, toe pressures, can be more reliable as the toe arteries are less often affected by this calcification. Transcutaneous oximetry, measuring oxygen levels through the skin on the foot, can also give good information about tissue perfusion.
Okay. And there was a classification system you mentioned for foot ulcers.
Right, the WIFI classification. It stands for wound, ischemia, and foot infection. It's a way to combine information about the wound itself, the degree of blood flow reduction, and the presence of infection to better predict the risk of amputation and guide treatment.
Got it. So a really thorough look at nerves, skin, and blood flow is crucial. Let's shift to treatment. When someone has both diabetes and PAD, what are the main goals?
Two main goals, really. First, improve limb outcomes, reduce symptoms like claudication pain, prevent ulcers, avoid amputation. Second, reduce their overall cardiovascular risk, prevent heart attacks and strokes.
And how do you achieve that?
Aggressive risk factor modification and medical therapy are the foundation. We know that hitting specific targets for blood sugar, blood pressure, and cholesterol can cut the risk of cardiovascular events by up to 50% in people with type 2 diabetes.
50% reduction is huge.
It really is. It shows how much impact good management can have.
Let's start with the feet again. Preventative care seems vital. What does that involve day-to-day or year-to-year?
Absolutely vital, given that triad of neuropathy, ischemia, and infection risk. Early detection and treatment of even small wounds is key because of the impaired sensation.
So what are the recommendations?
Regular screening is number one. That means an annual comprehensive foot exam by a healthcare professional, including that Semmes-Weinstein monofilament test for neuropathy.
Okay, annual check.
Then, huge emphasis on patient education. Teaching patients and their families how to inspect their feet daily, proper nail care, recognizing warning signs, the importance of appropriate footwear.
Footwear makes a difference.
A big difference. For high-risk individuals, custom therapeutic footwear might be needed to offload pressure points. And underpinning all of this is good glycemic control, aiming for that HbA1c below 7%.
Right. Let's talk about glycemic control again. You mentioned aiming for an A1C around 7%, not necessarily super tight control like below 6.5%. Why is that?
Yeah, it's a bit counterintuitive, perhaps. While good control is definitely crucial, especially for preventing those microvascular problems like retinopathy and nephropathy.
Eyes and kidneys.
Right. Several very large trials, Accord, Advance, VADT, looked specifically at whether pushing HbA1c levels really low, like under 6.0 or 6.5%, would reduce heart attacks and strokes compared to standard control, around 7%.
And what did they find?
Surprisingly, they didn't find a significant benefit in reducing major cardiovascular events. And the Accord trial actually found an increase in cardiovascular deaths in the very intensively controlled group.
An increase. Why would that happen?
We don't know for sure, but potential reasons include more episodes of severe hypoglycemia, low blood sugar, maybe faster weight gain with some therapies. It's complex, but the bottom line is that for macrovascular risk, extreme tightening beyond about 7% doesn't seem to add benefit and might carry some risks for certain patients.
So 7% is generally the target for most.
That's the general recommendation from the American Diabetes Association, balancing microvascular benefits and macrovascular safety. Of course, targets can be individualized.
Okay. And what about the types of medications used to lower blood sugar? Are some better for the heart and blood vessels than others?
Yes, absolutely. This is an area where we've learned a ton in the last decade. Metformin, which is usually the first-line drug for type 2, has a good track record and seems to improve cardiovascular outcomes.
Okay, metformin first.
Then, for people who need more, especially if they already have cardiovascular disease or are at high risk, two newer classes have really stood out in large trials.
Which ones?
The GLP-1 receptor agonists and the SGLT2 inhibitors. Many drugs in these classes have shown clear benefits in reducing heart attacks, strokes, cardiovascular death, and even hospitalizations for heart failure in some cases.
So doctors are now choosing based on cardiovascular risk too, not just sugar lowering.
Exactly. The guidelines incorporate this now. Lifestyle and metformin first. Then, if more is needed, you consider the patient's cardiovascular risk profile. Do they have existing heart disease, kidney disease, heart failure? That guides the choice towards agents with proven benefits like GLP-1s or SGLT2s. Insulin is still used when necessary, of course.
Interesting. Okay, beyond blood sugar, what other risk factors are critical to manage for someone with diabetes and PAD?
Oh, definitely cholesterol, dyslipidemia, and high blood pressure, hypertension. And then there's the question of antiplatelet therapy.
Right, let's do cholesterol first. What's the approach there? You mentioned ASCVD risk earlier.
Yes, ASCVD is atherosclerotic cardiovascular disease, heart attack, stroke, PAD. For pretty much all adults with diabetes, especially those over 40 or with other risk factors, moderate or high-intensity statin therapy is recommended to lower LDL, the bad cholesterol.
Statins are key then.
Absolutely. Major trials like HPS and CARDS showed significant benefits of statins in people with diabetes, reducing ASCVD events, even if their starting LDL wasn't super high.
Do LDL targets matter as much, or is it more about using the right intensity statin?
It's shifted more towards ensuring the patient is on the appropriate intensity of statin based on their risk profile, rather than chasing a specific LDL number, although LDL reduction is still monitored.
And if statins aren't enough, or someone can't tolerate them?
There are other options. Ezetimibe is often added, and for very high-risk patients, newer agents like icosapent ethyl or the injectable PCSK9 inhibitors have shown additional benefit on top of statins in some trials for reducing MA's major adverse cardiovascular events.
Okay. What about blood pressure? What's the target?
Controlling blood pressure is crucial. It definitely reduces macrovascular disease and death. The current ACAA guidelines recommend a target of less than 1380 millimeter Hg for almost all adults with diabetes.
Lower than the old 140/90 target.
Yes, based on evidence showing that more intensive control down to 1380 reduces cardiovascular events and stroke further.
Okay. Now, antiplatelet therapy. Aspirin. This seems confusing lately. Should people with diabetes take aspirin to prevent heart attacks or strokes?
It is confusing, especially for primary prevention, meaning people who haven't had an event yet.
Right.
For secondary prevention, someone with known ASCVD, like a past heart attack, stroke, or established P8 aspirin, or sometimes another antiplatelet like clopidogrel, is generally recommended.
But for preventing the first event?
That's where it's murky. Some older guidelines recommended low-dose aspirin for primary prevention in diabetics considered high risk. But more recent large trials specifically in diabetes, like ASCEND, ARRIVE, haven't shown a clear net benefit. The reduction in heart attack strokes was modest and often offset by an increased risk of bleeding.
So, no routine aspirin for everyone with diabetes anymore?
Generally not for primary prevention, no. It might be considered for certain individuals, say between 40 and 70, who have a very high calculated 10-year CBD risk and a low bleeding risk, but it needs to be a very individualized discussion with their doctor.
What about for people who already have PAD?
For them, it falls under secondary prevention, so antiplatelet therapy is generally recommended. Aspirin or clopidogrel are options. Some studies, like Capri, suggested clopidogrel might be slightly better than aspirin in patients with PAD, including those with diabetes.
Any newer approaches?
Yes, there's growing interest in dual pathway inhibition. Trials like Compass and Voyager PAD looked at combining low-dose aspirin with a very low dose of the anticoagulant rivaroxaban.
A blood thinner.
Right. And this combination showed promise in reducing both MACE, major adverse cardiovascular events, and MALE, major adverse limb events, like amputation or needing urgent revascularization, in patients with stable CAD or PAD, including many with diabetes compared to aspirin alone, although bleeding risk was higher.
So more options, but also more complexity in choosing the right strategy.
Exactly. It requires careful balancing of clotting risk versus bleeding risk for each patient.
Okay, besides managing all these risks, Are there treatments specifically to help with PA symptoms, like the claudication leg pain?
Yes, definitely. The first-line treatment, and often the most effective, is exercise therapy.
Just walking.
Structured walking programs, yes.
Oh,
Either supervised in a clinic or a structured home-based program. It's been shown consistently to improve how far people can walk before the pain starts. It helps improve blood flow, endothelial function, and even glycemic control.
so exercise is medicine here.
Very much so. It's recommended as the initial treatment for intermittent claudication.
What if exercise isn't enough or someone can't do it?
There's a medication called cilostazol. It helps dilate blood vessels and has some antiplatelet effects. It improves claudication symptoms in about half the patients who take it, including those with diabetes.
Is it widely used?
It's often recommended for a trial period, maybe 3 months, for people whose claudication really limits their lifestyle, provided they don't have heart failure, as it's contraindicated then.
And when do things escalate to procedures like angioplasty or bypass surgery, revascularization?
The decision to refer for revascularization is usually based on the severity of the symptoms or the threat to the limb.
So not just based on test results.
Not solely, no. It's indicated for claudication that's truly disabling, meaning it significantly interferes with work or desired lifestyle and hasn't responded adequately to exercise and medical therapy, or, more urgently, for critical limb ischemia.
Which is?
That's when the blood flow is so poor that the person has pain even at rest, or they have non-healing ulcers or gangrene. That's a limb-threatening situation requiring intervention. Non-healing or infected diabetic foot ulcers where improving blood flow might help healing is another key indication.
And the criteria are basically the same whether you have diabetes or not.
Generally, yes. The thresholds for intervention are similar, although the procedures themselves might be technically more challenging sometimes in patients with diabetes due to the pattern of disease we discussed earlier.
This has been incredibly thorough. Thank you. Let's try and summarize some key takeaways from this deep dive.
Okay. Well, I think first is just the scale of the problem. Diabetes is common, it's growing, and it carries a huge burden, both economically and personally.
Right. And its impact is largely vascular.
Exactly. It damages blood vessels big and small, leading to devastating complications. Blindness, kidney failure, heart attacks, strokes, amputations. Understanding that vascular connection is vital.
And management is multifaceted.
Absolutely. It's not just about blood sugar. It's aggressive management of blood pressure, cholesterol, using the right medications, including newer ones with proven cardiovascular benefits, plus lifestyle, exercise, and crucially, meticulous preventive foot care.
What was one thing from this that maybe surprised you or stands out as particularly insightful?
I think the whole story around intensive glycemic control and macrovascular outcomes is really fascinating.
How tighter wasn't always better for the heart.
Right. The fact that those big trials challenge our assumptions really underscores that managing diabetes is complex, and we're still learning the nuances. It highlights the need for ongoing research and personalized approaches.
Yeah, that's a great point.
Also, maybe just the sheer impact on the lower limbs, the PAD, the neuropathy, leading to that shocking statistic about amputations, it really drives home how interconnected everything is in this condition. What seems like a foot problem is deeply tied to the underlying systemic disease.
It really does. So maybe a final thought to leave our listeners with. Given this global rise, the immense costs, the human suffering, what does this mean for us as a society?
That's the big question, isn't it?
What kind of innovative thinking do we need beyond just new drugs? Thinking about public health, food policy, urban planning, education. How do we really turn the tide on this epidemic and lessen its devastating impact?
Yeah, it's a massive challenge that goes way beyond the clinic walls. It demands creative, multi-level solutions.
Something definitely worth pondering. Thank you so much for sharing your expertise today.
My pleasure.
And thank you for joining us for this deep dive.